Hello and welcome to the ASCO Daily News Podcast. I'm Geraldine Carroll, a reporter for the ASCO Daily News. My guest today is Dr. Allison Zibelli, a breast medical oncologist and assistant professor of medicine at the Sidney Kimmel Cancer Center, Jefferson Health. Dr. Zibelli will highlight key posters on breast cancer that will be featured at the 2022 ASCO Annual Meeting. Her full disclosures are available in our show notes, and disclosures of all guests on the podcast can be found on our transcripts at asco.org/podcasts. Dr. Zibelli, it's great to have you on the podcast today.
Thank you. It's nice to be here.
Let's begin with abstract 1021 and the phase 1 EMBER study. Can you tell us why this study should be on our radar?
So this study was very interesting because it's testing a novel therapy, which is imlunestrant, an orally bioavailable SERD, or a selective estrogen receptor degrader. This drug is for patients with ER-positive, HER2-negative advanced breast cancer, and they're presenting updated data from the dose escalation phase and the dose expansion phase of the EMBER trial. This trial enrolled 138 patients at a median age of 62 years. The median number of prior therapies for these women was 2. The adverse events were low. They could have prior platinum therapy, but no prior fulvestrant or aromatase inhibitor. The premenopausal women in the study received concomitant GnRH antagonist. They had substantial clinical benefit with this therapy, with no dose-limiting toxicities. It had a favorable side effect profile with no cardiac or ophthalmic safety signals, and it had excellent efficacy in heavily pretreated ER-positive advanced breast cancer patients. This is the first study showing efficacy and safety with an oral SERD. And we're all looking for new, oral, well-tolerated therapies for our metastatic estrogen receptor positive breast cancer patients. These patients were heavily pretreated and they had a median of 2 prior therapies. Most of the advanced breast cancer patients had prior endocrine therapy. 92% had a prior CDK4/6 inhibitor, 50% had fulvestrant, and 26% had chemotherapy. Despite this, they had an overall response rate of 5% with a clinical benefit rate of 47%. So it'll be very interesting for us to see what happens with this new class of SERDs in the future.
Excellent. Well, moving on to abstract 514, this study addressed patients with high-risk early breast cancer who received pembrolizumab within the neoadjuvant biomarker-rich I-SPY2 trial. Can you tell us more about this study?
This is a very interesting study, which is a platform study comparing various investigational treatments to a standard therapy, which was ACT with or without Herceptin, depending on the HER2 status of the patient, versus an experimental agent. One arm of the I-SPY study was neoadjuvant pembrolizumab. This paper is very interesting to me because it's hard to know in advance who will respond to immune checkpoint inhibitors, and that's what this study was designed to answer. So they took 69 patients who were on the I-SPY study. They all had high-risk mammoprint scores. All of them were HER2 negative. And with these patients, they had 31 complete responses to neoadjuvant pembrolizumab and 38 patients with residual disease after neoadjuvant pembrolizumab. Notably, of the 31 complete responses, 12 were ER positive and 19 were triple negative. In the residual disease patients, 28 were ER positive and 10 were triple negative. If you compare this with historical data, the response rate for pembrolizumab is about 20% for triple negative patients and about 12% for ER positive patients. So the response rates that they had were higher in general. So what the study did was they found a signature of 53 genes, which they named imprint, which was identified with a greater than 90% sensitivity and greater than 80% specificity for predicting complete response to pembrolizumab in all patients. This worked equally well for the estrogen receptor negative and the estrogen receptor positive patients. In Keynote 086 Cohort B, which was presented at AACR, PD-L1 of greater than 1% only predicted a 23% response rate to pembrolizumab. So if we could use the imprint study to predict patients who would respond to pembrolizumab, it would save a lot of needless toxicity and a lot of needless expense treating the patients who wouldn't benefit. So this is going to be a very useful method to identify patients that we want to treat with pembrolizumab and perhaps other immune checkpoint inhibitors as well. I think this might be the next oncotype, as it were, in that it will be able to predict who will benefit from a specific therapy.
Well, let's move on to abstract 519. This is a randomized pre-surgical trial of alternative dosing of exemestane in postmenopausal women with early ER-positive breast cancer. What are your key takeaways here?
I thought this was a great design of a study. It was a window of opportunity test. So what they did was they tested 3 different dosing schedules of exemestane in patients waiting for surgery for ER receptor positive breast cancer. The patients were randomized to either receive exemestane 20 milligrams a day, the standard schedule, 25 milligrams 3 times a week, or 25 milligrams once a week for 4 to 6 weeks prior to surgery. Their endpoint was percent decrease in circulating estradiol. And what they found was the 3 times a week schedule was comparable to the daily schedule. The once a week schedule didn't seem to be adequate to decrease estradiol, but 3 times a week was equivalent to daily. This was really interesting because we know that our patients have difficulty tolerating aromatase inhibitors. We know from formal studies that about 25% of patients discontinue aromatase inhibitors prematurely because of side effects. Small studies in actual practice settings show it's probably even higher than that. Between 30 and 50% of patients discontinue aromatase inhibitors. So for the patient that can't tolerate daily therapy, 3 times a week therapy is an attractive option that may be just as good as daily. I think this is very important in patients who have to take these drugs for years, that they have a way to take them that is tolerable.
Absolutely. Well, the last study that I'd like to ask you about is abstract 1015. This looks at quality of life for patients with HR positive, HER2 negative advanced breast cancer. So, what does this study tell us about quality of life with CDK4/6 inhibitors?
So we have a lot of studies of CDK4/6 inhibitors, and we know that they dramatically improve the overall survival of women with ER-positive metastatic breast cancer. What we also know is that they have a lot of side effects. And for women that have to take these drugs for years, that's important. So this study was a matching adjusted indirect comparison study. This is a method that uses individual patient data to create balanced trial populations across separate studies. And they used patients from the Mona Lisa 2 trial, which was ribociclib plus AI, comparing to Monarch 3, which used abemaciclib plus AI. The endpoint was something they called time to sustained deterioration, which was a decrease in 10 points in the quality of life score. They used the QLQ-C30 questionnaire. The upshot of their data was that ribociclib was more tolerable, mostly with less appetite loss, less diarrhea, and less fatigue than abemaciclib. So this is one of the first studies we've seen that directly compares, well, sort of directly compares quality of life between these two drugs. And this may be a data point that favors ribociclib.
Thank you, Dr. Zibelli, for sharing these important advances in breast cancer that will be featured at the 2022 ASCO Annual Meeting. We really appreciate it.
Thank you very much for having me.
And thank you to our listeners for joining us today. If you're enjoying the content on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.